Hello, everyone. Welcome back to SADS Live from Sudden Arrhythmia Death Syndrome Foundation. So good to have you here. Seems like we were just together last Friday, and we were. Wasn't that a great program with Lady Glockenflecken? I loved it. I hope you enjoyed it as we closed out last month with the National Sudden Cardiac Arrest Awareness Month here in the United States. But whether you're in the United States joining us or over in Europe or down under, great to have you for SADS Live number 104. Good to be with you. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic and the Winland Smith Rice Sudden Death Genomics Laboratory. And I give you greetings on behalf of our CEO of the SADS Foundation, Alice Laura, and her team for joining us for Question and Answer Friday here on this first Friday of November. And November has ushered in Family Health History Month. Help get the word out. Know your family history. Is there a story in your history that would matter? Are there any warning signs in friends and families for the possibility for the presence of one of these genetic heart conditions that probably affects overall about 1 in 200 people have some sort of genetic heart muscle condition or genetic heart electrical condition for which we would want to know of its presence, because when we find it, when we know it's there, we can counter it, we can treat it, and then we expect you and your loved ones to live and thrive despite its presence. So good to be with you. Let's see the questions coming on in. Again, I think last month the One Beat Medical for donating the automatic external defibrillator, or the AED, and the winner last week, Mary New from Salt Lake City. So congratulations to them. And again, thanks to Lady Glockenflecken for joining us last Friday. Now, as soon as this program ends, I'll be dashing out of my office, running home, changing clothes, and heading to Chicago, where Chicago will host the American Heart Association, the AHA's National Scientific Meeting. Really, it's an international meeting. Scientists and cardiologists from all over the globe come for these next 3 days. And I'm particularly excited about AHA. We'll be having many, many members of my research team on the clinical research, the translational research, and the basic research presenting our work. And in fact, we have 16 presentations from Team Ackerman, both posters and digital posters and oral abstracts and lectures that will take place from our program over the next 3 days. And while I wait to see a question come on in, I'll give you a little snapshot, flyover of some of those presentations of what have we been working on. Really excited. Dr. Martijn Bos from my program will be giving a presentation on our artificial intelligence derived long QT syndrome mutation detector. Really exciting work where we can look at a 12-lead ECG where the QT is prolonged and be able to tell, is it prolonged because there's a mutation there? They have congenital long QT syndrome, or is it prolonged for a non-genetic reason? Maybe drugs, maybe electrolytes, maybe whatever. And we call it our AIECG LQTS mutation detector. So really excited about that abstract. We have more work with gene therapy from discovery from our lab with a unique approach called suppression replacement gene therapy. That's making its way. We're treating those rabbits as we speak who have type 2 long QT syndrome. But we've developed the gene therapy approach for the calmodulinopathies, one of the very rare forms of calmodulin-mediated long QT or calmodulin-mediated CPVT. So showing that we're working on that disease and our initial efforts in the dish look very promising. So quite excited to present that work. Well, I see a question coming on in, so I'm going to jump over to it from Julie. And great to see you, Julie. Can I explain the difference between what happens when torsades causes a seizure and when it causes SCA or sudden cardiac arrest? Great question. So torsades is the danger rhythm for the long QT heart. So when the long QT heart goes from its stable rhythm, albeit a prolonged QT interval, to a twitchy rhythm, to a danger rhythm, that danger rhythm is called torsades. When you go into torsades, if you go into torsades briefly, 10 seconds, 20 seconds, you fainted, down and out you went, but you woke back up because the torsades broke and then went back to normal sinus rhythm. But if you're in now torsades for 15, 30, 45 seconds and it hasn't gone back to normal, you fainted 30 seconds ago, but now at the 45-second mark and so forth, you've now showing what looks like a generalized seizure, because with the brain, with the heart beating like that in electrical chaos, we're not getting perfusion to the noggin, called cerebral hypoperfusion. And the brain then gets electrically ticked off and shows its electrical irritation with what looks for all the world like a generalized tonic-clonic seizure, a grand mal seizure, as they used to call it. But then the seizure stops, the person wakes back up because the rhythm went back to normal. If the rhythm is not going back to normal and they're staying in torsades, and now we're at 30 seconds, 50 seconds, 60 seconds, we are in sudden cardiac arrest. And then at that stage, in all likelihood, the only thing that's going to bring the heart back to normal is that automatic external defibrillator, the AED, and a rescue shock. I love the question, Julie. Thank you. Susan C., what are common reasons for long QT when it's not genetics? I love the question because, in fact, in the adult population, if a person is found to have a long QT interval, QT prolongation, it's actually far more likely that the reason is not genetic, especially when there's no family history. Remember, this month is Family Health History Month. So for that person who comes into the emergency department and for whatever reason they get an ECG and they note a prolonged QT interval, that is not immediately congenital long QT syndrome. It could be acquired QT prolongation, and a person could acquire that reversible finding for a variety of reasons. What medications are they on? There's 100 different FDA-approved medications that can prolong the QT interval as a side effect of the medication. What's their electrolytes? Potassium low can do it. Magnesium low can do it. Are there other health issues going on where that health issue, that condition, is secondarily aggravating the heart's electrical system, causing acquired QT prolongation? And then there is the genetic version of long QT syndrome called congenital long QT syndrome that affects overall about 1 in 2,000 individuals. Anne, hi Anne, is asking, at what age would I recommend exercise restrictions for a PKP2 positive kid with no symptoms and a normal EKG, normal MRI, and the mom is showing it? Oh, I love this question. These are 3 for 3. The reason I love it is I just had a patient this morning with PKP2 mediated ARVC, or sometimes we now call it ACM, arrhythmogenic cardiomyopathy. And we know that PKP2 is the most common genetic subtype for desmosomal or genetically driven ARVC. And we know from mouse and man that certain kinds of sports, particularly high intensity, prolonged endurance training sports, could be disease accelerating, for which I don't have my patients with PKP2 mediated ARVC do marathons, do long distance running, rowing, cycling. But I do let my patients with PKP2 who are athletes and who want to be athletes try to stay athletic. Now, in this case, when your son is in the phase of what you described, owning the mutation, PKP2 positive, but not showing the disease, for them, I try to let them do their sport of choice as long as it's not marathon, long distance this, long distance that, but let them stay and play. And then I check their testing yearly. And I don't tell him or her that I'm going to pull the rug out from under them at any specific age. Instead, we look to see, are they ever going to declare themselves as the penetrant one, where they start to show the disease? And if so, we might have to make adjustments at that point in time. But we know that you can own the mutation and never show the disease. And so we try as best we can to let them, even those with PKP2 ARVC, stay and play. It's just that we adjust exactly what is the stay and play about no marathons. Can notch T waves from Jenna be caused for other reasons than long QT syndrome? Yeah, there's a lot of notch T waves. There's notching and then there's notching. So there's certain T wave looks that show a notch, but that notch is really more of a T wave followed by a U wave, and that could be nothing. There's a characteristic long QT looking notch T wave when that's due to LQT2. And there, the T wave notch has a particular look in it, showing itself in particular leads. So there's a lot of different things that can make the T waves look funny or look notched. Karen, questions are coming in, so it doesn't look like I'll be able to give you some more of our abstracts that we'll be presenting tomorrow, Sunday, and Monday, but these are good ones, really good. Karen, is your college son decided to put Narcan next to all AEDs in dorms. If someone is having a sudden cardiac arrest, if given Narcan, can that make it worse? So that's an interesting question. Never had one like that. So Narcan, as you know, obviously we're dealing with the profound tragedy throughout the country of fentanyl overdosing, fentanyl coming through our borders like candy. And the death toll out there is unacceptable. So squad cars, paramedics, first responders, they have Narcan. That's the antidote to morphine, opioid, fentanyl overdose or toxicity. And in somebody who is unconscious and they give Narcan, naloxone is the generic name, it won't hurt if the person is actually in sudden cardiac arrest. So it cannot, I don't think there's any evidence to suggest that giving the Narcan could make things worse. And again, given the fentanyl overdose epidemic, statistically, if we find somebody down and unconscious, it's probably more likely to be a morphine, opioid, fentanyl overdose than it would be sudden cardiac arrest in the first place. Christine, question number 5, 15-year-old with CPVT, doing great on Nadolol and flecainide. When originally diagnosed 4 years ago, was put on Nadolol twice a day, 2019, flecainide twice a day. You know other people with CPVT. Oh, this is a long question. Christine, make these pithy for me. I know other people, but take the full dose instead of splitting. Is there a reason for the dose? Yes. So this is really important. Nadolol is a very long-acting beta blocker. I love it. And so when the liver becomes more adult-like, 8, 9, 10 years of age, we can do the Nadolol once a day, no problem. From birth to say 8, 9, 10, I usually use the Nadolol morning and evening, and I divide the dose. For flecainide must be given morning and evening. It is not a once a day medication unless the person by chance is a super poor metabolizer of flecainide. And that's very uncommon. Only about 3, 4, 5% of us are poor metabolizers of a drug like flecainide, where then you could take advantage of that and give it once a day. But almost always, flecainide must be given morning and evening. Great questions, and we're rolling. James has found to have the RYR2 gene mutation. If it's true, that mutation can cause either CPVT or one of the newer entities that we call calcium release channel deficiency syndrome, sort of the opposite side of the RYR2 coin. Just like mutations in the sodium channel can either give you LQT3 or Brugada syndrome. But back to James' question, found to have it. They call it, the genetic test company is calling it a VUS. We've talked about those. After his cardiac arrest, the treadmill epinephrine test came back negative for CPVT. The echo and MRI looks completely normal. What would be the next steps to find out what happened and why? Wow, good question. If the treadmill stress test is normal, then that cardiac arrest almost for sure was not CPVT, meaning that RYR2 VUS is either not the cause at all, certainly not the cause for CPVT, but may in fact, I should have read the rest of your question first, be this newer entity of calcium release channel deficiency syndrome, whereby the ECG may not show it, the stress test may not show it. In fact, usually does not. It's a challenge. So what I would be doing, for example, in your situation is I would have a CPVT expert staring at your genetic test result and trying to decide whether we think it's stuck as a VUS or whether we think it is in fact a pathogenic variant. And if so, then it's more likely to be the calcium release channel deficiency syndrome side of the equation. Lori, 9-year-old boy, asymptomatic, has long QT, starting on Nadolol at 20. What side effects are concerning? Well, Lori, first, the good news is most people tolerate their Nadolol beta blocker very well. So I think sometimes in social media and so forth, those who are hating life on beta blockers, and there are those like that, they call them the beta blocker zombie. That perspective gets a little bit echo chamber amplified. So first, most agree with it. Second, the way they're starting it in your son at a lower dose and working their way up is perfect. But then what side effects concern me? Well, anything that's bothering you, because you know your son better than anyone. And so do you see any changes that are concerning to you? Does he or she feel any changes? The two reasons why we change strategy from Nadolol is if the beta blocker is causing unacceptable fatigue, or if the beta blocker is causing unacceptable mood change. Those are the two most common reasons where if we have to change course or make an adjustment, those are the leading reasons why. But again, most, as in at least 2/3 of all of my patients where we try Nadolol, we stay on Nadolol and it works really, really well. Dee Dee, hi Dee Dee, been sharing this to my group as much as I can. Question, SCN5, I'm the only person in the world with this. Since I've gotten older, it's showing up all the time. Well, Dee Dee, that's a tough one because I'm not exactly sure what that means in terms of the label. So I don't know whether you're trying to show a variant that's LQT3 or Brugada or what. So I might need you to reach out to the team at SADS Foundation to give more information. So I read these all in real time, so I don't filter through them. And unfortunately, I'm not going to be very helpful, at least right now. Lauren, related to long QT, if a patient has normal electrolytes, not genetic, not medication, what are some reasons that a person has a long QT interval? So you're making it pretty good in the sense of it's not genetic long QT syndrome. It's not electrolyte long QT prolongation. It's not drug-induced QT prolongation. What could it be? Well, there's several health issues. So somebody who's septic, very sick, their QT interval will be longer than somebody who's not. Somebody who's diabetic, their QT interval might be longer than somebody who's not. Somebody who has rheumatoid arthritis, their QT interval may be longer than somebody who does not. So there's several health issues, but I think one of the other things is your QT interval actually longer than it should be? So there's unfortunately a lot of people label a QTC of say 480, 470, 460, women, men, kids, as prolonged QT, forgetting that 1% of the planet, that's their number. And 1% of the planet does not have disease of any sort, electrolyte problems of any sort. So I also, in that setting, I would want to pause and say, do we even think the person has a QT problem? And is it reversible? Well, the QT, if it's prolonged for an identifiable, reversible reason, it's absolutely reversible. If it was because potassium was low, we correct potassium, we correct the QT, and so forth. Dee Dee's filling up the blanks for me on saying, I mean, LQTS and CPVT. Again, I wish I knew exactly what I'm to address there, Dee Dee. I'm just not getting it. So we'll press on and reach out to the team, and then maybe we could expand on that. Laura was recently diagnosed at age 37 with ARVC, but did not test positive for a mutation. Can ARVC be non-genetic? I'm wondering how this will affect your 3 daughters without a genetic mutation. It makes it tricky. Oh, great question, Laura. This is super important because you can truly have ARVC and truly have a negative genetic test. In fact, how often? Half the time. So in other words, we currently know 50% of the genetic basis for ARVC. The rest, the other half, may not be genetic, or it may be genetic still to figure out. But if we take the current ARVC genetic spell checker and we give that spell checker to people who truly have ARVC, I get a positive answer, PKP2, like the other person a few questions ago, DSP, so forth, half the time. When you are in the half where it's positive, life is less tricky because then you can go through the family members with variant-specific cascade testing, Family Health History Month, know your history, do the genetic testing and find out who did and who did not inherit the genetic marker. Those who did not can potentially be dismissed. Those who did need to be evaluated carefully. Now, if we are in the other half, like yours, where you don't own a mutation yet that's been found, you need to stay in the queue. You need to keep tabs with, are there any new genes being discovered that can be retested? That's not going to happen very often, every 3 to 5 years as a check-in. But in the meantime, until there's a way to know that you don't have something, everybody immediately related to you, your children, your siblings, must have a periodic cardiac evaluation to see whether they are or are not showing any measurable signs of ARVC. The frequency changes depending on the age, but initially throughout childhood and adolescence for your children, it should be yearly, maybe every other year if there's been several normal in a row, but they have to have regular cardiac testing when we're not aided by a genetic marker to tell us who does and who does not have it. That's such an important question, Laura. Thank you for it. Jen is asking, when do you proceed with genetic testing when your heart rhythm doctor doesn't have concerns, but you do, due to symptoms and the ECGs? Good question. Partner with your electrophysiologist, share what your concerns are. If you can't get reassured by the findings, then you need to explore, do you need to see another heart rhythm specialist? I think it's always better if a medical health professional guides the genetic testing rather than you just getting a genetic test on your own. Somebody from Facebook, so welcome that media platform, was diagnosed with Brugada syndrome. First time we did mention Brugada earlier, a few weeks ago. And you have an induced Brugada 1 pattern and a spontaneous non-specific type 2 and 3. Right now you have a loop recorder. So far I have not triggered an alert, but I have been feeling lightheaded most of the day. Do I need to really worry about it? Lightheadedness is basically never a Brugada symptom. Lightheadedness is almost never a symptom for any of our genetic heart conditions. So I would say the lightheadedness has nothing to do with your potential label. If you have an induced Brugada type 1 pattern, you need to have the Brugada syndrome genetic test. That genetic test is not as good as long QT or ARVC or CPVT. In other words, you can truly have Brugada syndrome, but the current Brugada syndrome genetic test will only come back positive about 20 to 25% of the time. But if you are that 25%, everything becomes easy. So I always like it when things get easy. But for the most part, if all you have is an induced Brugada pattern on that ECG, your likelihood of a Brugada triggered episode, even if you really do have Brugada syndrome, is super low. So Dee Dee's answering with who her doctor is, and he is one of my favorites. So Dr. Andrew Cron is a heart rhythm specialist in Canada. He's the current president of the Heart Rhythm Society. And fun fact, he was my third Winland Smith Rice cardiovascular genomics visiting professor. So you're in great hands, Dee Dee. I just can't quite tell with what you're asking. Gabby, hi Gabby. If the genetic test is positive for PKP2, does that mean they are also positive for ARVD even if they don't have symptoms? Great question. We kind of did this a little bit earlier. Maybe you weren't on at that time, but owning the mutation, PKP2 positive, KCNQ1 positive, any genetic marker positive, and showing the disease that is the normal possible sequelae of that genetic perturbation, genetic disruption, are not one and the same. The only time that is one and the same is if that genetic marker is what is called 100% penetrant, meaning I own it, I will show it. It might be a matter of time, it might be age dependent, but I will show it. And the good news is our diseases are not like that. That's what makes it tricky. Because if you knew you were always going to show it, then we would make certain adjustments sooner. But in our diseases, whether it's the channelopathies, long QT, CPVT, the cardiomyopathies, ARVC, ownership of the genetic marker does not guarantee showing the presence of the disease. It may never show itself. That's why you have to do the periodic surveillance, whether it's annually or every other year and so forth. So really important. So you can be what we call PKP2 positive, owning the genetic marker, but phenotype negative, not showing any measurable consequences of that disease gene association. What are the implications, Jason's asking, for misspelling of the genes SCN5A for Brugada? Well, not a lot, except it tells us that you have SCN5A mediated Brugada syndrome. And there's some suggestion that there's certain kinds of SCN5A mutations, truncation mutations, for example, that may show the Brugada phenotype easier than other types of SCN5A misspellings. Let's see, Jadid. Oh, I love that name. evening. Please advise. Oh, so you're somewhere in the evening. So I guess that's Europe somewhere. Please advise, is seizures connected to CPVT? 7-year-old with autism, now epilepsy and CPVT, very hyperactive. That can help to calm her down. That is safe with CPVT. Oh my goodness, that is a good question. These are amazing, amazing questions today. Like all of them, but man, you guys are on fire. So this is a challenging one. There's a lot we've learned about CPVT, ryanodine receptor mediated CPVT, the fact that that ryanodine receptor and a mutation in that RYR2 encoded ryanodine receptor not only builds the ryanodine receptor of the heart, but that same ryanodine receptor is located throughout the brain. Most of the time, though, when a person's having a generalized seizure, it's for that same sequence that I described earlier with torsades, meaning their CPVT heart went into the electrical danger rhythm. They were then out and unconscious for 30, 45 seconds. And because of that, with the heart doing this, their head now gets electrically irritated, cerebral hypoperfusion as the reason for the brain's electrical irritation, causing a secondary generalized seizure. That's the norm for the chain reaction. But we and others are wondering about the possibility of primary CNS brain mediated epilepsy from ryanodine receptor insult. That's way early in discovery and understanding. The autism part, however, is not. The autism part was published in the European Heart Journal a couple years ago. Lead author, my friend Arthur Wilda, we participated on it, where we showed, as best as a heart doctor could discern, that probably 7 to 10% of patients with CPVT have some measurable form of learning disability that includes autism and autism spectrum. And that number is probably an underestimate. I bet it's higher, but it's not the norm. In other words, the vast majority of my CPVT patients have no evidence of cognitive neurological deficit, but 10% do. Those who have CPVT and concomitant ADHD, or attention deficit hyperactive disorder, we intentionally treat their ADHD. In fact, one of our abstracts being presented in Chicago is about our early experience with ADHD therapy for our patients who have CPVT, where we have decided that leaving their ADHD untreated when they clearly need treatment is causing more harm than good. And so our initial early experience shows that yes, we can treat ADHD if you have well-treated CPVT and not have that stimulant therapy aggravate your CPVT. Stay tuned to that. That's still pretty early, and we're learning about that. Lene, great to have you join. And Tisha, oh, thanks on Bella. So looking forward to that. And on the 7-minute counter, Lauren, if a patient has no symptoms, asymptomatic, and is on beta blockers, hopefully Nadolol, with the QT interval showing 465, is there any concern for a fainting episode or heart attack? Well, first, I like that situation, but it's not a cure. I would never be able to declare that with a QTC of 465, nothing will ever go wrong, but we're in a really good starting point. So if I like the medicine that you're on, I like the dose that we got to, I like what I'm seeing on your ECG Holter stress test, then I would be very, very optimistic. The best places in Canada for a specialist. So I'm hesitant to do the best because I have so many friends in Canada. And if I don't give the right name, but I'll give you a couple. Andrew Cron, I mentioned his name. Shu Sanatani is the head of our pediatric CPVT registry in British Columbia, Vancouver, BC. great pediatric heart rhythm specialist, special friend of mine. There's others. Dr. Robert Hamilton in Toronto for ARVC. I could give several others, but then if I leave somebody else out, then they might be upset. So hopefully that helps. You're very welcome, Laura. And 5 minutes on the counter. I think I might get through all of them. Wow. But I better do it. Hillary, long QT1, pacemaker. Oh, then the one comes in. 80 of Nadolol. That's a good dose. What exercise causes the clavicle pinch? Example, swimming, butterfly, gym exercise. Is it true that the clavicle pinch can damage a pacemaker wire? Well, a couple things there, Hillary. I'm guessing you actually have a defibrillator and not just the pacemaker, because we don't use a pacemaker by itself for LQT1. But regardless, there's a lead that if you had the generator placed underneath your clavicle, where certain things could pinch where that lead entered that subclavian vein to then go and find its way into the heart. Increasingly, the way we position that lead makes that clavicular crush or clavicle pinch less likely, but rotational things like the butterfly stroke, I suppose, can do it. But I don't see this very often, honestly. So I don't think I would be necessarily worried about it. I try not to limit the motions that my patients can do when they have the device. Coming to Marsha, well, I'm looking forward to having you come. And we get the final one at the top of the hour with 4 minutes to go from Julie to enjoy Chicago. And she even gave me a pizza recommendation. And oh, do I love pizza. So I might do that. So we are off to Chicago as soon as the counter hits 2 p.m. Central Standard Time, or 9 p.m. for those who joined us in some places in Europe. And 16 presentations are going to get underway. I mentioned a couple of them. Artificial intelligence, long QT mutation detector, really excited. Gene therapy for the calmodulins, very excited. Our experience with ADHD stimulant therapy for patients with CPVT. We even have our first presentation on the small subpopulation of long QT Brugada patients who identify as transgender, and it's a very small number, 0.3%, but where their exogenous sex hormone therapy could potentially be heart rhythm irritating depending on which direction we're going hormonally. That's interesting. We want to make sure they're safe if they are having that kind of therapy. So we're presenting that work. We're presenting our work with return to work for high endurance workers, military, fire department, police officers, and we're grateful for those professionals. What else are we presenting? We have new drug that we have been working on from a company called Thrive Therapeutics. The public release has been put out. We show the early results of their drug to shorten the QT interval in the dish. Super exciting. It looks very promising. It's obviously super early, but the clinical trials for that drug in patients with long QT syndrome is probably going to get underway and enroll potentially in the next 6 to 12 month territory. Let's say a year from now, we'll be enrolling. So that's exciting. That, I think we have 1 minute left to think of another presentation. And I think we did all of them. Let me see if there's one that's jumping out at me here. I think we're going to call that good as we reached the top of the hour mark. And it's great to be with you. I'm grateful for this, for the families and patients who I personally have the honor and privilege to care for here at Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic is truly an honor. To have all of you part of the SADS family, whether I personally see you or don't have the privilege of caring for you, we're so glad that you're choosing to be part of the SADS family. Partner with us. If you have the means, and donate to the SADS Foundation, www.sads.org, and the red Donate Now button is the top right corner on the website. Or if you know somebody who might have means and resources and desire, share it with them and have them partner with us. More money, more mission, as one of the famous nuns of St. Mary's Hospital here at Mayo Clinic once said. So until next time, and next time is actually going to be 2 weeks from now. Join me next time, Friday, November 18th. Until then, be well, be safe, live and thrive, and blessings to all of you.